Good evening and welcome to members, officers, the press and members of the public joining this meeting. This is a meeting of Newham's Health and Wellbeing Board. We're also inviting you on the YouTube channel to actually follow the agenda pack, which you'll find on the Newham Council website. Any member of the board who's unable to join the meeting in person is able to join remotely, but we must stress that they will not be able to move or second a motion or vote. That's in accordance with local government guidelines. And just with regards to this meeting etiquette, please can I ask that you indicate that you wish to speak by raising your physical hand, and the chat function will not be monitored during the meeting. So welcome everybody, especially those who are joining us from remote places, I understand, not just in the London area, but all our health partners. Welcome to another meeting of the board. And in order for the agenda to be rescheduled, I've agreed that item 6 is heard last. So we're rearranging the agenda just simply to transfer the interim interim North East London integrated care strategy update to the last meetings due to Hilary, who cannot join the meeting because of other work commitments.
We're not taking it at all.
No, we are.
We're taking it, but it's last. Is that okay? Sorry, shall I make that really clear again? Because it's not clear. It's Hilary's running late, so we're putting item 6 at the end, just before the date of next meeting. So welcome everybody. Shall we do some introductions to those in the room? I'm Councillor Neil Wilson, I'm the Deputy Chair, and I'm standing in as chair at the moment because the Mayor, Roxana, is running late. Sarah, would you like to go around this way and we'll go around?
Good evening, everyone. Councillor Sarah Ruiz, Cabinet Lead for Children and Services.
Good evening, Councillor Joshua Garfield, Cabinet Member for Education.
That's Dr. Nackby, GP and Newham Primary Care Development Lead.
Give.
Julie Powell, Chief Executive, Health Watch Newham. Veronica Alwood, DK Manager, Health Watch Newham.
Claire.
Hi, I'm Claire Solly, Director of Quality Assurance, Safeguarding, Workforce Development, Adults and Health.
Colin.
Colin Ansell, Chief Executive Council.
Jason Strelitz, Interim Corporate Director, Adults and Health.
And just while we've got you in the room.
Pauline.Egan, Clerk.
And then can we, Julia, would you like to introduce yourself, please?
Sorry, Chair. Julia Stevens-Rowe, I'm the Independent Chair of the Children's Safeguarding Partnership.
And Fran.
Thank you, Chair. Fran Pearson, Independent Chair of Newham Safeguarding Adults Board.
Viola.
Adiola Agbabi, Public Health Newham, one of 2 interim Deputy Directors of Public Health.
Yeah. Tim.
Hello, good evening, Chair. Tim Aldridge, Corporate Director for Children and Young People's Services.
Marie.
Thank you, Chair. Marie Truma Abel. I work for NHS North East London. I'm the Interim Joint Director of Delivery for Newham.
And Mark.
Thank you, Chair. Good evening, everyone. Mark Gilbert-Cross, Director of Nursing and Safeguarding from NHS North East London.
Fiona.
Good evening, everybody. I'm Fiona Hackland, one of the Assistant Directors of Commissioning in the Adults and Health Directorate in London Borough of Newham.
Very much. Jack.
Good morning. Good evening. Good morning.
Jack Squire for all of us. Yes, don't worry about the hour.
Sorry about that. Jack Squires, I'm the Designate Nurse for Safeguarding Children for NHS North East London, and I work at Place in Newham.
Vic.
Good evening, everybody. I'm Vic Verma, Director of Education, including.
You may need to check the your signal, but we heard some of that. But Vic, would you like to try again, because we lost you midway?
Oh, sorry, if you can hear me now? Vic Verma, Director of Education, London Borough of Newham.
That's much better. Thank you very much, Simon.
Hi, thank you, Chair. Good evening. My name is Simon Ashton. I'm the Hospital Chief Executive at Newham University Hospital.
Very much. Rima.
Hi, good evening, everyone. I'm Rima, I'm a local GP and I'm the Clinical Director for the Health and Care Newham Partnership Board.
Welcome. Joe?
Good evening. I'm from NHS North East London. I'm the other half of the Director of Delivery post for Newham.
Very much. Seb.
Hi, Seb Brant, Detective Chief Inspector from the North East BCU, representing Public Protection Partnerships.
Thank you very much. Paul.
Hi, I'm Paul Calaminis, Chief Exec at East London Foundation Trust.
And Jessica.
Good evening, Jessica Ewan, Head of SEND.
Anybody else that I haven't introduced, Pauline? I haven't asked to introduce, rather.
There's just an officer who's off camera who I think is going to be helping Fiona a bit later.
Right, thanks very much. So item 1, apologies for absence. That number 1 was lateness from the mayor. Any other apologies received? Anybody else want to give apologies now? Item 2, declaration of interest. Are there any declarations of interest from members of the board? Thank you very much. Minutes of the last meeting. Thanks very much, Pauline. They're up pages 9 at Sequendum. Anything on accuracy, and shall we do accuracy and minutes arising together? Is there anything? We'll do it that way for efficiency. Page 9. Page 10. Page 11. There's an action point about the North East London Integrated Care Board on population need to be a standing item, and that's been observed, Pauline, hasn't it? Yeah. Health Watch update, pages 12, 13, then health equity, and there's obviously Adiola is going to talk more on that. Send improvements as a standing item. I'm on page 14. Stop me and buy one, as they say, if there's anything you wish to highlight. And then the aging well policy, 15. 16, domestic abuse, which has been deferred and it's on this agenda. Suicide prevention, that strategy was approved, and that's going through various iterations, which Sarah, Josh and I will know about as elected members. Thanks very much. Okay, shall we then move straight into item 3, 4, let's get the numbers right. Send improvement plan, standing item, education officers, children's services to introduce. First, yeah, good.
Thank you very much. At the last Health and Wellbeing Board, I provided quite a substantial update as to the work we were doing to improve the SEND service at the council. And I've since provided several updates at both scrutiny and full council. The key thing to update the committee on is the fact that, if you'll recall, the targets we set ourselves and we committed to in the written statement of action to A, clear the backlog of the EHCP by March 2023, that's education, health and care plans that were outstanding, taking longer than 30 weeks, clearing that cut-off backlog by March 2023. And secondly, ensuring that by September 2023, 75% of all EHCPs are being completed within the statutory time for 6 weeks. Very, very pleased to announce, and have been at previous occasions, that we have cleared said backlogs 3 months early. If you refer to the report on page 44, which demonstrates the total number of EHCPs issued 30 weeks and not yet issued, that reached a figure of 0 in December 22, so we're 3 months ahead of schedule, and we're expecting, given that the additional capacity that was approved by Cabinet in July can now go towards looking at current EHCPs, we're expecting to certainly meet the pre-agreed deadline of September, but possibly even meet it slightly earlier as well. I've got with us tonight, I've introduced already, Tim, Jessica and Vic. We're more than happy to go into more detail on specific items if people have particular queries in the report, but I'm very aware that the update of the last meeting was very substantial, so I'm quite keen to keep it as succinct as possible given the hefty agenda. Over to you, Chair.
Thanks very much. Any initial observations or comments from officers at this point? Tim.
Yeah, thank you, Chair. Just to build on Councillor Garfield's comments. It's pleasing that we've made progress against the backlog of assessments. The next focus, as Councillor Garfield said, is timeliness and quality. and there's a whole piece of work around implementing a review of the structure of the SEND service, and again, moving forward in terms of delivering on some of those other areas for the written statement of action, in particular, quality of planning, co-production, and understanding our data and sufficiency better. Thank you, Chair.
Thanks very much. Any other officer? Oh, Rima, sorry. Yeah. How would you like to come in at this point?
I'm so sorry. I'm trying to put my hand up. So thank you. I just wanted to say, I think it's really great as well in terms of the hard work that's been behind this. I went to actually visit the ASD diagnostic service a couple of weeks ago with Paul Galuli, and just fantastic team effort, just in terms of even having and the speech language therapists and their sort of leadership approach to carrying out those assessments, I thought was fantastic. So well done to the team, and I hope that that sort of continues as well. So I just wanted to say that. Thank you.
Thanks very much. Thank you. Yeah. Any further comments on this report, Sarah?
Just really whether there was any update in the report 3.31, page 50, on the procurement of the host organisation to take forward the Parents Forum. I noted that the application process closed on the 10th of January, and I know it does take a little while, but I just wondered whether there was any update.
Chair, Jessica might be able to provide an update. Jessica, I don't know if you've got an update on that particular item.
Yes, thank you, Tim. Just to say that we're really pleased with the way that the procurement process has gone thus far. It is moving forward. As you say, Sarah, these things do take a little bit of time, but we're meeting regularly with the Newham Parent Care Forum to get that support network in place so we can further extend the co-production offer.
Thank you, Jessica.
I'll bring you in because I've got one. Roxanne and I've got questions, but anybody else on the call or any further? Roxanne, sorry.
Just wanted to ask, appreciate the focus of the next phase is going to be on quality of reports, and just wanted to get a sense of the journey travelled thus far, the requirements of the WOSA as defined by DFE Ofsted and the CQC. How much is the achievement around number of cases that have been dealt with more a case of just getting them through in order to meet a requirement over actually the experience of the child and the family dealing on the other end? And I appreciate that there's going to be a substantive, as rightly there should be, on quality. But what elements of quality can we be assured of now, given the period of concern that there has been around this piece, vis-a-vis service delivery and the partnership involvement all round?
Sure. So you recall the update at the last meeting, we spoke at great length about how the timeliness of the HCPs wasn't the sole focus. Without achieving that, it's very difficult to look further and to achieve more. Second thing was the quality and ensuring that they were done through co-production. And that is, of course, ensuring that it's centred around that young person and involving our health partners, families, school settings, etc., and the local authority. We have now restructured the department, and we have brought in a quality assurance lead, which is part of an established role within the council that is there to ensure that the quality of each individual plan meets our new expectations with regards to the WOSA. Jessica has some information about the workforce development piece, if I could bring her in, please, Chair.
Yes, thanks very much. Jessica?
Yeah, thank you very much. We are, just to sort of answer your question, Mayor, it was really important that we issued that substantial backlog of plans that kind of developed during COVID and improved our timeliness, which we're kind of seeing really positive indicators around. What we are really committed to doing is driving a programme of workforce development that ensures that staff have very clear expectations, support and challenge to give the level of service that we owe and are very motivated to provide our local families. In terms of the quality assurance work, it has been ongoing for some time. So we have a multi-agency approach to quality assuring our work. We're working hand in glove with the DfE. So our DfE advisor spent Monday, the whole of Monday, with a multidisciplinary team, really supporting us to critically review what we do and seek every opportunity to continue to improve the quality of our work. As Councillor Garfield says, co-production is at the absolute heart of that work. So we're going to place a real emphasis on having early conversations with families, being outcomes oriented, and as I say, kind of, ensuring that we are hitting and exceeding those quality markers. Adding to that, the experience of families is ultimately what the quality of our work will be determined by. So we have kind of events that have been scheduled that will enable parents and carers to co-produce a practice framework with us, which will really determine and shape the narrative around the service that we provide and the experience that the families receive.
You wish to come back, Roxanne?
Just a quick one. I appreciate the future focus of quality. Perhaps I didn't ask my question well. Of those that have been processed, so that there are no longer any that are above the 20 weeks, what's the satisfaction rate? What's the satisfaction, insight of all of those cases that were in a 30-week plus time frame? Are they satisfied?
Thank you, Mayor. We are kind of improving our kind of feedback loop with parents and carers to understand in real time the level of satisfaction with quality. Our quality improvement is an ongoing process, and what we have done is we've brought our plan writing in-house. So the workforce development programme that we're delivering will ensure that our staff are better trained to focus on the quality assurance and ensure that co-production is at the forefront of our work. A dip sample of the cases recently found that the quality had improved, and we have and we've got a sort of a feedback questionnaire that's being provided to parents and carers so we can hear from them about their experience of the service. So we'll be kind of learning more, I think, as we go through an ongoing process about the satisfaction levels of those plans. We are hearing anecdotally from schools and settings and families that they are noticing a change in terms of timeliness and are pleased that they are no longer kind of waiting on backlogs and now have the statutory protections that the plans offer.
Shall we make clear, this is a standing item. I've got one more question, and that may tie up with how we take what's going to be on the next agenda, but clearly the focus on quality assurance and some reassurance for this board that it's not just timeliness, it's about the quality connected with the families and the young people themselves. Paragraphs 3.38 and 340 on page 51, big page 51. It ties up with the whole issue of transitions. The secondary and post-16 Senko network have been instrumental in testing, which is good, but feedback from the trial period was received at the December, although attendance at the group was lower, and has been used to iterate the template for its borough-wide rollout. So one of the fixations, I think Councillor Garfield will know, that we have is about transitions, because it's a national issue, but it's also important that we get the right partners in the room to participate within that. And then 340 is more the question from me. It says the diagnosis of a learning disability is not commonly used for under 18s nationally for a variety of complex reasons. I get that. Therefore, a dedicated exploration of the issues is being driven by local health, social care and educational psychology practitioners to identify how we ensure our pathways are led by need rather than diagnosis of this cohort. Any indication of whether we would have anything by next meeting on just progress on that? It's early days, whereas we're quite pioneering if it's not nationally recognised.
Yeah, I think, Chair, at the previous meeting, we talked about the capital bids programme that we have awarded in order for that transition be of a higher quality for our children and young people, because we know that it traditionally is a gap, both the children and young people send, and also it's a wider piece with the education team, and of course our partners in community wealth building, etc. We could certainly get some more detail for the next meeting on that transition. I know that Jessica will probably come in to talk a little bit about what our health partners are doing to help us get that data for you. On your previous point, just before I bring in Jessica, what I think might be helpful to illustrate the change in quality of not just our EHCPs, but the provision that is accessed by our young people, both the changing quality from our health partners and from the local authority, would be some testimonials.
Yeah.
Because I have spoken with a number of families over the past couple of months who have, in that one-to-one anecdotal that Jessica talked about, explained just how different their child experience is in the past 6 months as opposed to 2 or 3 years ago, and how they've really noticed a shift in quality. And I think that beyond the data, because we can chuck data at the committee, of course, but those testimonials probably will illustrate that better than anything else. And I'm sure we can pull some together for the next meeting. But I'll hand over to Jessica for the transition question specifically.
Jessica, just on this about the model developing where diagnosis of a learning disability not commonly used for under 18, but we're working on a new modelling of that.
Yes, and that work is underway, and I'm sure we could provide further information along with our health colleagues when we next get together. Transitions on the back of the joint area inspection in December 2021, transitions and preparation for adulthood and post-16 provision are all key priorities for us, and we have been working with public health colleagues to kind of look at a needs assessment for that cohort of children transitioning into adulthood, and also looking at our sort of tripartite funding arrangements. So we are kind of getting together as multidisciplinary teams to better understand the challenges and to strengthen those pathways.
Thanks very much, officers. Thank you, Councillor Garfield. With the remember, this is a standing item that we'd like something on the quality piece in there. We'd certainly welcome some suggestions of the real lived experience, the case studies. I think that's really helpful. We're used to that in other areas on the health piece, and I think that'd be helpful. Yeah. Carry on.
I just one final comment, if I may, Chair. It would be helpful to know at what stage can we be presented as a board some qualitative data, so we're moving beyond anecdotal and a few or handful of testimonies.
Yeah.
Can I bring Jessica in on that?
Timescales, yeah.
But of course, at the moment we have focused on the quantitative data of commitments that we made in the WOSA. But that's definitely a question that Jessica can come in for.
Yeah. Yes, thank you. So since we last met, there's been a pulling together of multi-agency quality assurance tools to kind of formulate a coherent quality assurance framework, which the DFE are currently reviewing. I think for that framework, which contains a sort of suite of quality assurance measures that will capture the voice of parents, carers, children, young people, include DIP sampling and practice learning conversations, surveys, a whole range of activity in order to sort of embed that efficiently and then gather some qualitative and quantitative data. I think we could sort of come back in September and have something to share that would give you a real picture of what the quality is looking like.
Thanks very much. That's very good. Thank you. Thanks, everybody, for their contributions and hard work in this area. Certainly on a long journey, but a lot of progress made already. So thanks very much. Health Watch, who have been in the building almost as long as me today, but who's introducing your Health Watch report? Veronica?
Yeah.
Thank you very much.
Hello, everybody. So today I'm here to present to you our findings on the discharge report that we carried out in partnership with Newham General Hospital over the course of February to July last year. This project was aimed to evaluate the patient's experience of the discharge process, particularly from the AAU, which is the acute assessment unit within Newham General Hospital. Just drawing your attention to a few of our conclusions, we found that most respondents, about 62%, reported that they were satisfied with discharge time and they had no issues with discharge. 79% of respondents mentioned that they were treated with dignity and respect during their stay and received the treatment that they needed. The majority of respondents frequently identified that nursing staff were nice and supportive to them. Whilst many were satisfied with their discharge time and had no issues, and were generally had a positive experience with discharge, 38% did acknowledge that they weren't happy about the discharge time, and the main reason for that was due to delays. 51% of patients were clear about the ways of contacting the hospital if they had any concerns. However, 49% of patients reported that they had no particular idea of how to contact the hospital if they had any further concerns. Some of our key recommendations recommended that all patients should be involved and informed in their care plan, including any services that they anticipate receiving, any treatments that they might be offered by the hospital. Some patients did note in the full aspect of our report that they felt as though that things were just happening to them. They weren't really involved in speaking with the clinicians about their care. For this, we suggest that hospital staff should check in with patients to check that they are able to understand the information that's shared with them. And we further would suggest that these conversations should be taken as soon after admission to avoid patients feeling unprepared for discharge, which was some of the sentiments that were pulled in our wider report. We also recommended a communication strategy involving all teams and the discharge of patients should be established to integrate care and minimize confusion and unnecessary delays during discharge. Some patients noted that the dispensation of medicine was one of the key bottlenecks of their discharge process. So with that, we recommended that hospitals should maybe consider reviewing this process of discharge. And we know that within Newham General Hospital, there is some quality improvement work looking into medicine dispensing and discharge as well. We believe that this will improve the discharging of patients in a timely manner. And finally, we also recommended that all patients should be informed verbally and in written ways of ways to contact the hospital post-discharge whenever they arise. And as we noted that this wasn't done as consistently with the patients that were discharged from the AAU. In total, we had I think of 149 people considered to be taking part in this survey. So we had quite a large sample area, and we asked the board to recognise our findings.
Thanks very much for your hard work on this. I think Simon first, if you wanted to respond at this point. Simon?
Thank you, Chair. I'd just like to thank Veronica for her work on this. It's been a really good joined up piece of work between Health Watch and the hospital. We take on board Health Watch's recommendations, and we look forward to working with them in the future to improve our services for our local residents. So it's been great, really. We fully accept the areas that we need to improve on, and we'll work hard to do that. Thanks very much.
Con.
Very much, Chair. Just a quick question. In terms of those you surveyed, what pathway were they coming through?
So they were coming through the acute assessment unit. So those tend to be short-term stays, mainly people that had been admitted through A&E, and then they went into acute assessment. Maybe they would have been in hospital for about 1 or 2 days before being discharged.
So a follow-up. Yeah, because in terms of the discharge pathway, so 0, 1, 2, and 3, I'm just trying to get an understanding of whether these were people on pathway 1, because obviously some of the delays may be more than just the hospital. So if you're talking about pathway 1, that could potentially go over into some social care.
Yeah.
So if you're trying to get a feeling of what the respondents, what pathway they were coming through.
Yeah, good question. Yeah.
Yeah, so we wonder if Simon would be able to comment on that, just because we know that the patients that we received from the AAU, the sample area was provided by the hospital, so they've shared their patients.
Back to you, Simon.
Thank you. I haven't got the exact breakdown, Colin, but there'd be a mixture. And you're quite right. Often discharge is delayed because of other things. It's not often because of the patient waiting for medication to leave the hospital. That's probably the minority of cases. And the patients that can just leave by themselves or with family picking them up often go very quickly and easily. The ones that take longer to leave are cases where we've got to arrange care packages to start. We've got to clean up houses. There's the range of social issues that we have to manage prior to discharge can be really quite significant, actually. And increasingly, Newham residents are subject to that full range of social conditions. There aren't, in terms of our discharges each day, I would probably say 70 to 80% are discharges which are fairly complicated in the fact that they need some sort of ongoing care or equipment. The minority of those that can actually get up and walk out of the hospital themselves or with family members.
And you wish to come back?
It was only very briefly, just in terms of if we was to repeat this process in the future, maybe probably more for Simon, if we could have a breakdown of that, because I would be interested in the correlation, say, to those on pathway 0 that felt actually their delay was because of something that they should have had. So therefore, should they have actually been on pathways? It'd just be an interesting area to examine if we were to do that again.
Thank you very much. I think Addie had her hand up.
Sorry, thanks, Chair. This is a really interesting report. Thank you. I was thinking from the public health perspective of opportunities to continue to connect and grow around some of the assets we're developing in the borough, particularly in that Newham space, looking at the connecting people to supports around the social determinants of health. And I know we've had some initial, the beginnings of initial work with NUH around starting to think around some of those spaces. So I welcome an opportunity to come and think about how we can connect a bit more and get that signposting into community assets as kind of standard to do with discharge planning, and sharing those connections. So that there'll be more of that infrastructure coming online during the rest of this year. So I look forward to the opportunity to be able to share and support the development of that.
Anything further? One from me, if I may, Simon. You said it was a relatively minor thing, but it has been the experience of people using not just Newham General, but say the London or other sites, that dispensation of medicines can hold up the process. You said it's a relatively minor thing. We've had some comments that there's a quality improvement project. Just, would you be able to sort of follow up that, not a major report on it, but in terms of, the linking in with what Colin was suggesting about further work on how we do a bit more dissection of how this is going at a future date. I'm not putting you on the spot on a timescale, but would you come back with anything on those?
Yeah, happy to do that. The dispensing of medications for discharge is not just about pharmacy dispensing the medication. That's usually the quick bit. The slower part, or where there are delays, are in the doctors writing out the prescription that then goes to the pharmacy for the dispensing. Now that can be subject to various things. That could be dependent on how many doctors we have available on the ward that day. It could be about planning. It could be about there's a whole range of things which can impact on the doctor writing out the TTA in a timely manner. We call them TTAs, to take away. Writing out the prescription. So it's often the prescription writing which is the delay to dispensing medication, not actually pharmacy dispensing it.
Thanks very much. Jason.
I think it's a really, really helpful report. Thank you very much. And that's Simon as well, because it's clearly a collaboration between Healthwatch and the hospital. So thank you. The one of the findings that I'm really drawn to is the 63% who reported their diagnosis and treatments were explained to them in a way that they understood, which means, 37 not responding positively to that, although, most of those people said they understood some. And I just think, that is, there's probably some truth to that across the country. Medical information is complex. We don't always fully understand it, but I mean, that's clearly a heightened issue in a place like Newham with the challenges of language and the language of health literacy. And I just think I think that would be something really concrete, actually, to think about how that's focused on. And clearly, if what we're interested in is preventing people's health from deteriorating, them understanding their diagnosis, their treatments, their self-management recommendations, all of those things is absolutely vital. And it just feels like it's a really concrete thing that that could be focused on. And actually, that's not just for NUH. I mean, I think that a lot of the findings in this report probably equally apply to social care. They equally apply to health. They equally apply to primary care. There are probably there's some kind of core stuff in there that I imagine is pretty universal across our health and care system.
Yeah. Yes, really good points made. Anything further on this? But thanks everybody. The hospital, Simon and your staff, and obviously Healthwatch. A good report, useful. Thanks very much. So we move on then to, we're doing item 6 last, remember. We're going on to item 7, the domestic abuse strategy. Fiona, to introduce it? Oh, sorry, Mumtaz, you want to introduce? Sorry, I keep leaving officers, members out of their introductions. Mumtaz, sorry.
So some people know the domestic abuse strategy 2025 section 2022 to 23 was signed by Cabinet on the 9th of June 2022. It was officially launched on the 25th of November. And it was developed with partners from across the local authority and key local partners in health, criminal justice, education and domestic abuse service. The strategy used data from a broad range of partners and learned from domestic
Sorry to interrupt, Mum. Can you check a bit more?
and co-production and consultation events took place with survivors, residents, employees, national and local domestic organisations and community groups. I'll pass on to Fiona to give us.
Thank you very much. Fiona.
Thank you, Ken. Would you like me to share the slide deck, or is someone there going to do that?
Yeah.
Can you share it, Fiona?
Absolutely.
You've got sharing.
Thank you. Am I sharing now?
Yes. Is that the same as what's in our pack, Fiona?
It's a long time since we've used Zoom as officers, so it kind of gets a bit not quite sure. It doesn't work quite like Teams. So good, excellent. Okay, so this is really an update report in terms of where we are with the domestic abuse strategy, and a kind of overview of how we got to where we are as well, to actually develop the strategy. So actually, let me just try and put this into a screenshot. Okay. So in terms of methodology, there was quite a lot of work done before we actually ever started writing any parts of the strategy. Obviously, we were kind of looking at the landscape in terms of what else was out there, what partner kind of local authorities were doing. what legislation was around, particularly in the light of the fact that the Domestic Abuse Act had been enacted in April 2021, and also the development of a kind of multi-partnership working group to look at what was out there. We knew what we commissioned, and we knew of some other pieces of work that were out there, but we weren't entirely aware of absolutely everything that was going on in Newham around domestic abuse. There were a lot of organisations working in this. So we have I would say now, as a result of that, a very kind of high functioning, well attended implementation group for the strategy and action plan. Many people are on that group that are on this call, or many organisations that are on this group that are on this call are on that group as well. And it continues to meet regularly and works in a really strong partnership way. We had lots of our partners actually doing a self-assessment of their approach to domestic abuse and how they felt that they were able to deal with it. And again, a lot of partners are very honest about how they felt they were able to respond to domestic abuse in terms of how well equipped they felt they were and how trained they thought their staff were and what they needed to be able to respond in what they thought would be a more effective way. Obviously, we looked at kind of local data, and there's a range of data, some of which is more complete than others, but we used what we could get hold of. And part of the work, as you will see in a bit, is improving the data that we collect around domestic abuse so we can get an ever improving picture. Unfortunately, in this borough, we had more than our fair share of domestic homicides. So I had a lot of domestic homicide reviews that we could look at and the recommendations that resulted from those. And a lot of co-production and consultation with survivors, with residents, with employees of the local authority, with domestic abuse organisations and community groups. And we were able to kind of pilot a model of co-production with, particularly with survivors and residents who've been affected by domestic abuse through family members being survivors, where we were able to offer them support as they took part in co-production in case they found that upsetting in terms of thinking about their own experiences. So what all of that led to was us developing some key vision principles for the strategy itself. We wanted to look at a kind of whole community approach that focus on the individuals, families, perpetrators, the community and wider society. Obviously, we wanted to kind of increase safety, very strong message around holding perpetrators accountable for their actions, but doing that in a way that offered them support. That we were very cognizant of intersectionality and the multiple needs and barriers that survivors have told us they may well experience as a result of living with domestic abuse. Obviously, the Domestic Abuse Act finally made it very clear that children and young people who experience domestic abuse in their families are survivors in their own right, and that we continue to embed the voices of survivors and residents in our responses to domestic abuse. There was a kind of common agreement to take a public health whole community approach to domestic abuse, which again builds on some of those visions, where we would respond to the individuals who were approaching us by understanding their unique experiences and the situations that they had found themselves in. That we would very much take a whole family approach that recognised the entirety of the family as being affected by domestic abuse, and also that while holding perpetrators to account, we would try to offer them support in order to change their behaviours. That we would take that whole community response to domestic abuse, so that we would work with our wider communities in order to understand how they can respond to domestic abuse and kind of where they can report, etc. And then also that we wanted to be campaigning about domestic abuse, both through kind of awareness raising and kind of doing education work, etc. around domestic abuse from quite a young age. Because this is a kind of whole organisation issue, there's a moderately complex but not massively strategic governance to this. So the domestic abuse strategy sits underneath a subgroup of the Community Safety Partnership and reports then obviously to that and also to the Health and Wellbeing Board, hence why we're here as well. But obviously there needs to be that dotted line of regular updating and reporting to both the Safeguarding Adults and Safeguarding Children's boards, because clearly there's a strong link with that. In terms of other links, we, as I said before, we kind of looked at other strategies and policies that we had within LBN, and also some of those that are developed by partner agencies. So there's strong read across to some of the other strategies that were developed at around the same time, so that we have the same aims, outcomes and outputs, so that we're not going around measuring different things and doing slightly different activities about the same things. There's a very strong read across some of those. We devised 12 priorities, and each of those has some sub-priorities and outcomes and kind of outputs, so that we can measure whether or not we've actually achieved those priorities. So that, again, we're not kind of talking anecdotally about it, but we have some measurable things that we can report on that we've been able to achieve. Next steps, as Councillor Khan said, we launched a strategy on the 25th of November, a very well attended event at Chargeable Lane. We received, as all local authorities did, some small amount of funding to help us implement our duties under the Domestic Abuse Act, and we have used that piece of money to commission an organisation called Safe Lies to support that partnership with the implementation of the strategy and the associated one-year action plan. So they'll be acting as our kind of critical friend and kind of, you know, challenging us in a constructive way around the work that we're doing around implementing the strategy. We're continuing to include survivors and residents in monitoring and revising the strategy and its action plan. They need to hold us to account on that. And again, the annual action plan informs the achievement of those overall strategic priorities. And one of the things that we'll be doing in the next few weeks is revising the action plan for the next year. And we'll be bringing that back to Cabinet in June, and the 1 year anniversary of Cabinet signing off the strategy. We also have a monthly domestic abuse strategy working group where we use a tool that I'll very briefly show you in a minute to monitor progress against each of the outcomes with partner organisations, either internal to LBN or external partners, reporting back on kind of how they're moving towards achieving some of the outcomes. And then that gets taken to the Community Safety Partnership quarterly meetings and then onward through that governance process. Just to kind of show you, this is the kind of action plan reporting that we're using. That's across the broad priorities, and then each one of them has its own kind of priority area where we are able to hold people to account and say what's being implemented, what's not being implemented, and what's going to be done to further work that's going to be done to implement things. In terms of current progress, as a few of you will know, we are currently about to start the procurement of our community domestic abuse service. So we are reviewing that model to make sure that it continues to meet the needs of residents, and there will be a new service in place later in the year. The responsibility for collating the data set sits within the Community Safety Partnership, and the data analyst who does that work is making increasingly good inroads into obtaining and analysing that data from partners, so that that intelligence that we need to kind of inform what we're doing gets better, certainly on a kind of quarterly basis. Our housing team, it's a action in the housing and sleeping strategy and also in the domestic abuse strategy that they will be pursuing Domestic Abuse Housing Alliance accreditation to make them an organisation better able to respond to the needs of survivors approaching them for housing issues. We are continuing to develop work across agencies about interfamilial domestic abuse. We have become aware over the last few weeks that there are not shared understandings across partners around how to work with survivors who have no recourse. So we're undertaking a quick piece of work to produce some guidance around what people can access and what they can't access, because I think there are some bits of misinformation kind of floating around. And sitting within the Community Safety Partnership, there is a piece of work taking place, particularly around women's safety, including an app that can be used for women to report any concerns if they feel unsafe. Finally, we are looking at some of the work that we're doing corporately around doing trauma-informed work and integrating, understanding the impact of domestic abuse within that in terms of working with both adults and children. We continue to develop our work with residents, as I've said, and we will be involving them in the reprocurement of the community domestic abuse services. In children's, Caring Dads as a parenting programme and Safe and Together as a training and good practice resource will continue. There is also, in terms of the next point around entering into a joint bid, Home Office have released funding for perpetrator programmes, which in London is being done through MOPAC. As the Police and Crime Commissioner, we have entered into a bid with 8 other local authorities to get money to create a culturally competent family-based perpetrator programme. That's currently with MOPAC. MOPAC will be sifting those applications and deciding what they then put forward to the Home Office. But as part of that, MOPAC are also considering putting forward their own proposal to deliver Safe and Together on a London-wide basis. So there's a kind of bit of discussion about how Safe and Together goes forward. We're very mindful that as an organisation ourselves and as our partner organisations, that we need to review our domestic abuse policies for LBN staff and develop resources and equip managers and staff to know what to do should there be reports of domestic abuse within our staff groups. And we are looking at our current comms programmes, made a good start with the launch in November, but how do we kind of continue that and continue to kind of send messages out to our residents. So we are looking at what are we doing generally in comms programmes, and can we include content on domestic abuse, as well as doing some specific domestic abuse work. And apologies, that is it. And I will attempt to stop sharing now, if the servers let me.
Thank you very much, Fiona. Questions or observations? Sarah? Huh?
Yeah, 1 or 2 of each observation.
Oh, yeah, you're allowed, you know.
Allowed. So firstly, I think that it was a really well attended and very good mix of people at the event. Certainly a lot of survivors and residents, and that was really encouraging in how they were willing to share their experiences in what was really, I mean, yes, it was a safe space, but it was quite big. So thank you for that. And I think, you know, we need to have more of those type of events. Then I have 2 questions on the domestic abuse working group. Do we have representatives of survivors and residents? And if we do, great. If we don't, how do we report back? Where does that loop? How do we make that loop so that we keep those people informed? And my second question was on housing. How confident are we that the housing officers that our residents meet up with are sufficiently trained and knowledgeable in dealing with domestic abuse issues?
Thank you very much. Good questions. Fiona to start, and others.
I might actually hand over to Shars, particularly on the first one. She was waiting for that. I can see her laughing now, so I'm going to hand over to Shar on the first one.
Shar first, and then back to the Fiona for the second, possibly.
Yes, sure. I can. Hello. I can provide a response regarding survivors and residents and the working group. So our co-production throughout the strategy has been very much led by survivors and residents and their choices about how they want to be supported, how they want to lead on co-production, and how they want to be engaged with. So that's an ongoing process at the moment, and we've got another meeting in Canning Town next week, because they are still deciding how they would like to hold us accountable and how they'd like to participate in the working groups. They've been clear that they don't feel that they want to join the actual working group that we have every month. They feel that they want to set up their own forum. So we're just currently putting that together at the moment. And just to say, co-production has been embedded throughout our domestic abuse work in the last 2 years. So I meet on a monthly basis with residents and survivors in the co-production team to keep them updated on the action plan and the strategy, and to keep them included. And they feed in directly every month, and their voices then get fed back to the working group through myself. So it's an ongoing process. It's not a static process. It's constantly evolving.
Great, thank you, Shar.
Anything else, Sarah?
No, that's fine. And the housing.
On the housing one, this is about, one council's approach on how we're getting the training through to all people who deal at the really tough interface sometimes. Yeah. Housing, Fiona.
I might push Sharon for a bit of this as well, but one of the things that we have done in the last year or so is actually embed one of the workers from the community service actually in the housing team. So that they are able, that's an approach that we've also found very successful in Children's MASH, which has been going on now for about 4 or 5 years, if not more, where there is an element that we're putting in place in terms of actual training, in terms of training events as well from the service provider, but often having an embedded expert within the team that people can go and ask questions of on a daily basis, or just go up and ask kind of questions about a particular case, we often find is actually a bit more successful in terms of changing culture and improving practice. So it's a bit of a two-pronged approach, I think, in terms of having those embedded workers and then actually doing some training programs. As part of the DAHA accreditation, the housing team actually has to put on specialist domestic abuse training for all of its staff and assure itself that that's actually being kind of used as part of their day-to-day practice. I think Candida ultimately would be better to answer that one, but that's certainly part of what they have to do is to gain the DAHA accreditation. I don't know if you want to add anything, Shar, to that.
Yes, so there's the housing team have identified a couple of sort of domestic abuse pathway leads that we can refer into, and also be given their names to residents where there's presenting domestic abuse. And I think these two individuals worked really, really hard and provided some really excellent responses, and sometimes very short time frameworks. I mean, like a couple of hours to move a family and access them safe emergency accommodation. So we've seen quite a shift, I think, in the last couple of years with these two individuals at the moment. And I think that's something they're developing as part of their DAHA accreditation as well, to train more officers. And these two people have already started to do that as well.
Thank you very much.
Any further? Sorry, Mumtaz, yes, do come back in. Yeah.
Sarah, I know you've raised housing, but there are other departments that the team is working with. For example, the maternity service and other early intervention services where the training is being provided, and we'll be working very closely with, because we understand that we may be missing significant casework where we could pick up, do some early intervention work.
Yeah, thank you. I mean, I know that certainly the New and Nurture work very closely with Acorn, etc. And so, I mean, I do think that we are getting much better in support and identification. But I was particularly interested in the housing, and that's really based on stuff that comes to me as an elected member. And although I do refer people, there's always part of me that thinks, oh, okay, is that going to be all right? So it was just really out of interest. But thank you.
Yeah. Now on the current progress slides, Shah or Fiona, on this one, you did mention, and I think it's important that we've got clear messages, because you did mention in terms of no recourse to public funds, the penultimate bullet point. I don't think the page is a number, but it's under current progress. They're undertaking specific partnership work to address health survivors. It's not about naming and shaming, but how are we going to make certain that we do get consistency on that? You said that that's undertaking some specific partnership work. Is that either Mumtaz or the officers on timescales that we can expect that to? Yeah, Fiona?
So we wanted to do something very, very quick, because we had a meeting of the group that specifically looks at the action plan, and there were partners there who were kind of asking questions about NRPF. So I think there's something that we're pulling together very quickly around, and in particular, Emma Cockrell's a really key member of the group, and she was talking about, being very, very clear about the access to support from children's that women with children or who are pregnant can have if they are NRPF. there were some things coming out about people being asked to pay for refuge, etc., that we need to address and kind of get information out. So there's something about pulling together actually what it is that people can approach services for and can obtain when they have no recourse to public funds. And then there's a discussion within that group about how we best disseminate that to practitioners. Because I don't think anyone was doing anything, certainly within that group, maliciously. They just genuinely didn't know. I think they were taking that sort of blanket approach to, if it's no recourse, it's no recourse to anything. Whereas that's just not true, particularly where there are children or pregnant women involved.
Yeah, thanks very much. Now, we've obviously, there'll be commissioned Safe Lives under the funding stream. You mentioned that work commences from today, as it were, 1st of February. So there's a review process that we'll undertake on that. But in terms of the recommendations, everybody, including those online, because it's addressed, obviously, that this goes jointly to a community safety partnership. It will segue neatly into the report that Fran and Julia will be talking about in terms of reporting lines to safeguarding, for obvious reasons, safeguarding boards, but it also goes to a community safety partnership. But it's, are we content to note the progress against the priorities? The recommendation on page 120, note progress against priorities. Remember, this is very much a work in progress together with all partners, and consider where it's quite a mild word to consider, but, you know, we do need, I think, you know, to consider very deeply how we all might play an active role in supporting delivery of the strategy, whether it's at primary care, whether it's at the hospital, whether it's police partners or health, what any of the partners involved within this board. If I've left anybody out there, the mental and community health services, including and beyond delivering priorities and outputs set in the action plan. But I think we can all agree that this is something that, with the current cost of living crisis, with the pressures on the health services and the resources, both for the health service and adult social care and others, with children's social care, that we do need to work very closely on this. So thanks very much for the hard work for Fiona and officers. Jason, to have the last word. Do you want if I not covered enough of?
Yeah, really. Just one thing that I wanted to say, which is not for discussion for now, but I think there's something very compelling for the board and challenging to think what the campaign element of this may look like, and what we want to achieve with that. And I think it's something maybe we should return to, because I think, you know, if we develop that right, if we can all get behind it as partners together, you know, it will absolutely have the most impact.
Yeah. And Roxana wants to come in now to campaign, which is fine.
And it was just really on the campaigning point. And I've been listening obviously intently to all the conversations and the presentation, and it's really welcomed. And it's given the epidemic, albeit pandemic proportions and scale of what we're dealing with. I'm also interested in the girls element and actually the broader landscape that we need to be engaging in to sort of, you know, to reverse the escalation of the hard stuff that this strategy in large part deals with. So, you know, the role of education, how we change culture, how is all that being done? Because this strategy is great, but where does it sit as part of a wider?
Yeah, which is why I kind of said it's a huge challenge. It's
Some good points, everybody. Thanks very much, Roxana. And I think we can all agree that this is, you know, something that this board, together with the community safety partnership, there's been some good work on the app, for instance, about, you know, making certain that's available, and that's going to the community safety with my colleague Carleen leading on that. But it's about how we get the right communication when we want to definitely see that there's no longer an upward trend on the line graph, but to make it at least, you know, going on a proper course. So thanks very much. Now I have to formally put something to a vote at this point, I think. So can we, for those who are present in the room and members of the board, for members of the board physically present, may I see by a show of hands that we're agreeing the recommendations as page 120. I think that's carried. Thank you very much. Now, over to our patient and independent, because I don't think I should introduce too much more. Fran's had me for 3 times already, and welcome, Julia. So Julia and Fran, I don't know if it's going to be a double act in terms of the Newham Safeguarding Adults and Children Partnership Annual Report. So
this is Chair, thanks very much. So I'm pleased to, we've all introduced ourselves really. So in a moment, I'm going to hand over to Julia Stevens-Rowe. But our statutory partners are here in the room or remotely tonight. And I think this is a good opportunity to thank them as well for all the support they give to Julia and myself. Now, this might be a multitask too far, but I'm just going to attempt to share our slides as well. Okay. Oh, okay. That looked promising for a second. Just have to do it again.
Fran, do you
opened?
No.
No.
Nothing's happened at this end, I don't think.
Okay, that's the rather depressing answer that I hadn't wanted. Let's see if that helps.
Fran, I think the slides have been sent out as a supplementary to the papers. So
Yeah.
I think, Chair, that people have got them. If you'd
We're
like
on.
us to start.
Sorry, yeah, I didn't realise that I was going to be having to do that job. Otherwise, we practiced it.
Oh, here we go.
Somebody's showing them for us. That's fantastic.
Yeah.
Thank you very
As if
much.
by magic, Pauline.
That was really magical. Thank you, Pauline. I'm going to hand over to Julia now.
Thank
So,
you.
For the benefit, sorry, Julie, but for the benefit of people in the room, there is a supplementary on your email. I hope that was sent out. Okay, yeah. Thank you.
Yeah, that was sent out, but you've now got the slides in front of you. So thank you, Chair. So the purpose of this is to, it's an annual event that we are very pleased to come and talk to you about the annual safeguarding reports for the year 2021 to 22. And we'll also provide an update on the shared priorities that have been in place for a while. So on the next slide, there's reference to all age exploitation, which has been a shared priority of the Children's and Adult Safeguarding Boards for the last 3 years. This priority is led by Seb Florent from the Met Police, who's on the meeting tonight electronically, and also Michelle Edwards, head of the Youth Justice Service. And we're very grateful to them and the work of all of the partners in progressing this work. Within certainly the Children's Safeguarding Annual Report, there's a lot of information on the adolescent exploitation strategy, which has been demonstrating the progress and impact of this work. The multi-agency all-age exploitation audit, which was undertaken, showed good examples of multi-agency working both in children's and adults work, and improved professional challenge and information sharing, although we need to do more work on that around adult cases. And again, more details of that are within the report. There's also been a focus over the last 12 months, perhaps just a little bit less, around modern slavery, where there's been a strategy and action plan, and where there's also been development of training and encouraging organisations to have a specific point of contact. And we're very pleased that there's now a dedicated resource within the Community Safety Unit who's going to be actually taking this work forward, along with continuing with partners. So on to the next slide, please. Transitions, again, has been a shared priority, previously led by Jessica Wan, who was in attendance earlier, and is now led by Emma Cockrell from Children and People Services and Tony Joblin from Adult Services. And there's been a range of activity around this, and as you heard earlier on, there's a lot of work around SEND in particular. The Transitions Hub for those moving from youth offending service to probation has been a pilot and has been very successful in terms of reducing offending and in terms of reducing risk levels and homelessness, and again is detailed within the NSCP report. Now that the transitions board has been established, quite a lot of the activity is now being held within that, and so the focus of the two safeguarding partnerships is to ensure that safeguarding is considered at the transition points, as you would expect, and we just need to keeping an eye on that. In terms of the next slide, please, Pauline. This highlights the key achievements of the children's safeguarding partnerships, which are referred to in the report. I won't go through them, but it does link into the conversations you were having about domestic abuse and the impact of children, and the need to make sure that we're all working together around that. In terms of views of children and families, that's certainly evidence within the report, and we're working hard around data and information sharing, which has significantly strengthened the safeguarding system. Of particular note is, regrettably, we do have a lot of safeguarding reviews, but it's how we actually disseminate the learning and apply the learning and make changes within the system, and certainly there's some very good examples of that. And collectively, there's been a huge effort put in to the work of the safeguarding children's partners, and that was evidenced in the conversations through the successful Ofsted inspection, as well as showing improvements in safeguarding within that document, which is obviously very pleasing to everybody. And then just finally from myself, the future priorities, we've been doing some work within the partnership, looking at our learning from reviews. So we're going to be focusing on child sexual abuse, including intrafamilial sexual abuse and sibling sexual abuse. Children's mental health, we clearly need to do a lot to refine the scope of this priority so that we're not overlapping work that's being undertaken by yourselves and other colleagues. But we also want to make sure we have a continued focus on practice improvement and communication. And we really wanted to make sure that throughout our priorities, we'll be considering the impact of the cost of living. That's certainly a real concern for us in terms of safeguarding colleagues. What might that look like in terms of more referrals coming through, etc. And also to make sure we have a special focus given to care leavers and unaccompanied asylum seekers and refugees. I just wanted to thank, as Fran did earlier on, the NSCP executive representatives who are electronically in the meeting, health colleagues, police and Tim, and they can help answer any questions when we get to the end of the presentation. So I'll hand over to Fran if that's okay. Thank you.
Thank you, Julia. So the Newham Safeguarding Adults Board has continued to meet at the kind of pace and with the momentum that we developed during the pandemic. So we continue to meet as a full board every 6 weeks, and it has huge advantages in helping us try to balance the delivery of our priorities with business as usual. I'm hugely indebted to the board members who turn up and contribute a lot to that. So over the course of the previous year, we scoped out 3 priorities based on data and sort of risk that we'd noted to be emerging over the kind of preceding period. And these were around safeguarding and supporting living. So we're hugely fortunate in Newham to have such an ambitious transformation programme around supported living. But I think nationally and for us, because of some of the sort of provision that's not ours, but is built and delivered in the borough, there are risks attached to that. So we wanted to respond quickly. So that programme is underway. Self-neglect is a problem ever present, but exacerbated by isolation, people not coming out, not being seen during the pandemic, and now overlaid by the cost of living crisis. So a huge area for us to work on. And I think safeguarding professionals are forever struggling because it's incredibly tricky working with the Mental Capacity Act. And so we've got a programme of work set up to, or to be set up to tackle that or to support that work. Moving on to our sort of business as usual, we've carried on delivering that. Much of that has been assurance work around emerging issues in care homes and the private hospital on the patch. And I think what I've been really struck by is the sort of strength of relationships with the multiple important players. So very strong working between now ICB and the local authority, but also with the Care Quality Commission and with NHS England, who are crucial to keeping on top of risk and addressing it when things need to be addressed. So things have been pulled together impressively from my perspective. And then moving on to our future priorities, we have a newly established community engagement subgroup, which we now want to use to add value to our work. We are going to be drawing on the findings of our annual sort of audit, which is part of a London programme. And moving on to March, we'll be kind of looking at how we get the balance right between trying to do business as usual and do priority delivery. We know we've got a gap around learning and communications, but we've already managed to produce, thanks to our business manager, a newsletter in January, and we wanted to make that a regular publication. So the other thing I think that's become a feature of our board meetings over the last few years has been the opportunity to really talk about difficult areas that require close working between organisations. And I wanted to thank colleagues from ELFT and from BARTS for some of the joint presentations and issues that you've brought to the board. We've really benefited from those as well. So moving on to our upcoming joint priority, we're going to continue with our all age exploitation, which is an assurance piece. We're not so much doing the do as asking for assurance on it. And we think we need to be much more focused in the coming year. And that focus is going to be on those affected by exploitation and youth violence and those affected by modern slavery, which of course we're well set up to do. And we need to be careful not to overlap with work, as Julia said, that's part of the modern slavery programme. I think the piece of work in development, which we're about to start, is around developing a work programme around situations where the homes of vulnerable people have been taken over for the purpose of criminal activities, known as cuckooing. We had a really great joint session 2 weeks ago today, and it's amazing how much data people do hold on this, even if they don't call it by that name. So we need to begin to define it and aggregate it. We know our next steps. And then very timely that we're presenting after the item on the domestic abuse strategy. In a way, there's not a huge amount for us to do because it's all very much in hand, but there is an assurance piece, just light touch and periodically, to make sure that we're giving the right support to that, and that safeguarding remains sort of prominent, as it so far has obviously been in all that work. So thank you very much, Chair, and thanks for sharing the slides for me, colleagues.
Thanks very much for your hard work, Julia and Fran, and all the partners involved in these boards. There's a terrific amount of caseload and workload issues for you both, but also the partners involved. So can I just thank you and just say, in terms of the piece on page 10 of the supplementary about the new joint strategic priority around homes of vulnerable adults, which this cuckooing thing. I mean, it was a very cold room we were in at the Stratford Youth Home, but there was a lot of, it wasn't heated up. It was, I think, Claire, I'll bring you in if, you know, on that particular piece, if you don't mind, about how we might just develop that with health partners, because it's a really. Well, you come in then, Sarah, because you weren't there. You went in. Oh, right.
I'm interested in that bit as well.
Thank you. So in terms of cuckooing, it's a very underreported area of abuse and it's very complex. The very nature of it is very secret, and people who are cuckooed tend to be very isolated. So the contact with people and the ability to disclose and share is very limited. In adult social care, we have a data set, so we're able to identify, and there are very small numbers that we have at the moment in relation to cuckooing referrals, but they are coming in. A lot of people who are cuckooed probably won't have contact with adult social care. So we absolutely must, and this is a key part of this priority, be engaging our health workers, housing, community health, and colleagues, voluntary, private sector, families, awareness absolutely throughout the borough.
Exactly. Well, Roxana, sorry, I'm trying to help Grace and move some equipment. Sorry.
Sorry, just on the cuckooing issue, I suspect it's a deeply hidden tragedy of great scale across the country. And when you talk about, and you're absolutely right, the range of partners and agencies that need to be much more alerted to this issue, we also have to look at ourselves. I've actually come across a case where our ward councillors, who are the eyes and ears within those communities as much as residents, have been raising an issue and they're beside themselves, and were beside themselves, essentially banging their head on a brick wall when it came to speaking either to housing in the council or other parts of the council system. And, you know, it's great to hear that we're discussing this in this forum, but what assurance can we have as members that actually the organisation is taking it seriously and there's that system, not only a commitment to system change, but actually the doing and the action. And then also, you know, as on the member side, we need to be much more vigilant and alert because these are safeguarding issues.
Yeah. Absolutely. And we are at the stage at the moment of developing an action plan. So that will cover everything that we've talked about in this very short period of time. But there's also a huge exercise. So we have data in adult social care, children's services will have data, the police, safety partnership, housing. And one of the key actions within this priority is actually scoping this out. So where are the hot spots? Where are the particular areas where this is more frequent? People are talking about it more, and it feels like it's in the place where, and we're not quite there yet with this either, modern day slavery and human trafficking. So people in the community being the eyes and ears of a very underground type of abuse. And even in TV programmes at the moment, you're seeing cuckooing coming up in some very recent high profile TV shows. We're talking about it, which is helpful. So there's a lot of work to do. Even things like a refuge collector, you know, for seeing certain things in bins or behaviours. It's about making sure they know what to do with that information.
Yeah. And I'm sorry, Sarah, I just, in passing, as it were, just as a sort of note for reference, whether Roxanne and my political colleagues would agree that we might come back on in part of the training programme. We've done one that was a bit too congested in some respects, so it was time for a refresh so that members are also alerted to that, as you say, because we're the eyes and ears as well and community advocates for residents. So, sorry, Sarah.
It's all right. I was going to make some flippant comment about our refuse collectors noticing anything in a bin. But on the training, I do think that that it's got to be pitched at just the right level. So, I mean, what we don't need is like being deluged with just suspicions. But on the other hand, we need to equip ourselves with good tips and pointers to look at. You know, I mean, when we talked about modern day slavery and trafficking, I think there was probably a whole swathe of us who stopped using car washes and nail bars. I mean, you know, automatically that was where our mind went. But actually, cuckooing has been a concern for quite a long time, which is why I was really interested to see that it's on here. So I look forward to watching that with great detail.
Absolutely. And in adult social care area, I think one of the challenges of cuckooing is a lot of the people who are cuckooed don't have caring support needs that would mean they need the support of social care, but they still need protection and support, advice, information and advice. And an adult social care NUM, and it's not like this in every local authority's front door. We accept those referrals, if you like. We listen to those referrals and we provide that information, support, advice. So it's not just about statutory function. So that should be positive. And it also links into county lines. So there's a really good relationship with children's services. It's a really complex area. So
it is.
We're working.
But actually also with vulnerable adults.
Exactly. Now, any comments from colleagues on the call, not necessarily on that issue? Or
Seb's got his hand up.
Seb, sorry.
Yes, sorry, no, it was just to make the point from a police perspective that certainly my perception is that very much it is one of those problems that will and can be solved by community intelligence. Training professionals is great and it's really important, but the grassroots intel will come from communities. And I'm fully aware from having dealt with similar aspects where the information comes from grassroots intel, that does mean sifting through an awful lot of well-meaning concerns about nothing, but amongst that is the intelligence that delivers us some successful operations, both from an enforcement perspective and of course a safeguarding perspective.
Yeah, thanks very much. Thank you. Now, any other comments on the report in general or the specific?
No, just thank you.
Yeah.
For their work.
Oh, sorry, Mumtaz, did you want to come in? Sorry. Oh, Sarah said you finished, sorry. Let me finish the sentence. Mumtaz said, which is good. Sorry, Mumtaz.
Are we including young carers? Did I miss something? Are we including our young carers in the strategy? That's it, I think.
Comment about young carers, because we've obviously got the young carers piece as well, which is across a whole load of areas, but about how they might be part of this. Anybody want to respond to that one?
I mean, I think it was the case that the carers strategy was brought to us.
Yeah.
So our joint executive considered how we could make the linkages. I think it's one of those areas though where Julia, we'd always be wanting to have any suggestions from people who are currently working with young carers themselves about how we can improve things and what we might do, and any sort of linkages between cross-cutting areas that we've missed.
I think it would be good to have some overlap between the two, because I think there is a real need, and it'd be good to address it here at some point.
Yeah. So you're coming back obviously in a year's time, but there's a whole load of work that the two boards are doing. So thanks very much to all the members of those, and I'm sure that we'll continue this work, and especially on what both Roxana and Sarah and Mumtaz said, and Joshua and I would take back to our members about the community engagement, particularly what Seb said about the developing the intelligence, because it may mean that we have to sift through a lot of stuff, but it then might actually get the problem more recognised, understood, evaluated, and how we might deal with it. So thanks very much for the hard work of the two chairs and the report. Thank you.
Thank
So
you.
we're now on our final item. Have we been joined by the representative? Yes, I think we have, haven't we?
Yes, Hillary's.
Hillary's here. Well done. Hillary, we put you at the end, not because of anything about a priority, but just because of your other commitments. So thanks for joining us. So this is the interim North East London integrated care strategy update. And some of us in the room have had some say in this, so I might develop too long on with the item. So I'm glad an officer's here to present it. Thanks, Hillary.
Thank you very much. Thank you very much for having me, and apologies I couldn't be there in person tonight. I'm Hilary Ross. I'm Director of Strategy for NHS North East London. So just I'm not going to talk through the slides in your pack, but just to give you a quick progress update and a quick overview of this strategy. It's the strategy of the Integrated Care Partnership, which is the wider partnership created back in July, bringing together our community and voluntary sector, local authorities and the NHS across North East London. And the Integrated Care Partnership is responsible for developing an integrated care strategy for our whole system. And that strategy has now been finalised as an interim strategy in line with national expectations, and it's been signed off by the Integrated Care Partnership and formally adopted by the Integrated Care Board last week as well. And I should just point out that the version that you've got in your pack, because of timings with papers, is an almost final version, but it doesn't include the final comments from the Integrated Care Partnership. And just to reassure Councillor Wilson, who made some excellent comments at our partnership meeting, that all of those have been incorporated and they will be in the final version that is being disseminated as we speak. So the process, there's been loads of brilliant engagement and participation. So thank you all so much for getting involved, whether that was attending a workshop to talk about our sort of priorities or to think about how what collective action we can take on the cost of living crisis, or whether that's some of the rich discussions we've had in our place-based partnerships and health and wellbeing boards. And I think really where we've got to is there's some really strong alignment across the system, which gives us a really great platform, I think, for working together, supported by continued dialogue with local people, with local partnerships, and with our provider collaboratives going forward. So just very quick overview of the sort of key content of the strategy. There are sort of three main elements within it. The first is around the four already agreed system priorities for North East London. These are the areas where we want to really focus on all parts of the system working together to improve quality and outcomes and to tackle health inequalities. So the themes of babies, children and young people, long-term conditions, mental health and local employment and workforce. So in the strategy, we've really tried to build the case for change in these areas, identify that all parts of the system can take, and to identify also some of the success measures that would it demonstrate us making an impact. So that's one key area. The second one is it became really clear that given the scale of some of the challenges facing local people, that it was really important to think about how we work differently as a system and not just the sort of what we're going to do in terms of our priorities. So we came up through the engagement with 6 cross-cutting themes, which are about how we work differently as an integrated care system. The first one, I'm sure many of these will resonate with colleagues locally here. The first one is around tackling health inequalities, and we've agreed there's kind of 2 dimensions to this, and then 3 priority groups. So the dimensions are around poverty and ethnicity, because we know the linkage with health inequalities, and then the three priority groups: carers, including young carers, people with learning disabilities and autism, and people who are homeless and asylum seekers. So that's the sort of focus for the work on health inequalities. Secondly, we have a cross-cutting theme on prevention, both primary prevention through to sort of wider determinants of health, but also secondary prevention. And we know this is getting quite a lot of attention with centrally with NHS England at the moment, and thinking about what more we can do to focus our efforts and energies upstream. So prevention, then more holistic and personalised care for local people, rather than always thinking about things in sort of disease-based silos. You know, people are whole people. And the next theme is around co-production with local people as well, really drawing on local strengths and assets, and moving away from being focused so much on kind of need towards strengths and assets. Then creating a high trust environment that supports the integration and collaboration we want to achieve as a system. And finally, how we start to work more as a learning system, very much driven by evidence and insight from local communities, that is much more research active and innovative, to sort of have that cycle of continuous improvement, where what we do is driven by evidence and research, and then we really understand the impact of what we're doing and act on that to continuously improve. So that's the sort of how we're going to work section. And then finally, there's a piece also in there about what are the building blocks or the foundations of our system that we need to strengthen to support all of that collective action. So there's some stuff in there around improving our physical and digital infrastructure, which you know, a lot of people fed back through the engagement what more we need to do to do that. As well as some stuff around our financial strategy, how we get more investment upstream in prevention, how we support innovation and improve sustainability, and then critically, how we embed equity across the system in all that we do. So that's the strategy in sort of summary. It is now setting the direction for the Joint Forward Plan, which is the new 5-year delivery plan, which we are tasked with developing for submission as a draft at the end of March, and then to be developed further into sort of early summertime. We are also seeking to have more dialogue with local people. There's a big conversation with local people planned for the springtime, where we want to get more input into some of the themes in the strategy. And then finally, we are also expecting further guidance from the department in June time, which will be another point at which we will review where we have got to so far. But that's all I was going to say. Really keen to hear any feedback and thoughts, and particularly how we continue this dialogue with you as we take this work forward over the coming months.
Thanks very much, Hilary. Observations, comments from any partners, anybody in the room or online? As I say, I'm trying not to get too involved because I've been behind some of this, as already alluded to. It's interesting that with the title to the piece is, of course, and Hilary will probably hear me say this nearly every meeting, that it's a care strategy that we're awaiting, I'm sure, with bated breath, further guidance from the Department of Health and Social Care in June. We do need to actually recognise that there's current structural inequalities in funding mechanisms, but also it's in the context of population growth. So you would expect me or Roxana or any of the members or officers present not to say we need to keep that sort of dialogue going about how we're not taking from but adding to, and all of those sort of issues around per capita funding. WAC, sorry.
I would just be, and thanks, Hilary, I would just be interested to hear how partners in the room feel that Newham can get involved in this strategy. What does it mean for Newham? How do we get involved? We've articulated a number of challenges over in our health and wellbeing boards around, you know, the 5 I's, as I call them: innovation, inclusivity, inequalities, inequity, and integration. How does our Newham Health and Wellbeing Board, how does our Newham Health and Care Partnership get involved and get the right things we need to get done for our residents and our patients? And it'd be interesting to understand, you know, what connections are already there and how we build on.
Yeah.
I guess my point is the kind of link between what you said, Neil, and what you said, Wax, which is I think the strategy is fantastic. Like there's nothing like I really like it. It's a vision that I find very, very compelling. But the proof of the pudding is how you translate that vision into meaningful action. And actually, I think within the constraints of our current local system in Newham, there's a lot of things that we're trying to do that align really well with that strategy. There's a lot of things still, there's a lot to do, but there is, as you said, Neil, a massive resource constraints that we operate within that fundamentally constrains our ability to do as much of this as we would want. And so that needs just constant focus, really.
And I did mention in a meeting earlier on that Claire, who's spoken in regards to the safeguarding issues, but was also, I think we were the only team out of the local authorities who sent a member to something on workforce. And I think that's, you know, I think Simon would concur that when I have discussions with him, we mustn't neglect the whole area of workforce. It's not just about training and numbers, but it's retaining people with a increased costs of living and, you know, commitment that we're trying to put through as people know in terms of London living wage and all the rest of it. I praised on Twitter today, for instance, that, you know, the hospital has brought back at Barts Health the in-house porter service, and it's all about all workers working together. It's how we make certain, what Wax has said, that we've been around some of these issues for some time now. It's about how do we make it work in the reality, not just at the hospital, but in primary care or in terms of our public health approach, community approach.
Got a couple of hands up there.
Oh, I've started something good. That's what I wanted. I'm trying to be. So Tim, and then
Simon.
Then Simon. Was it Simon first? Simon and then Tim. Do we do it in that order?
Yeah, sorry.
Right.
I'm happy for Tim to go first, Chair. It's fine.
All right, Tim. Then.
Thank you, Simon.
About this.
Yeah, no, just a few things. No, I agree with Jason. You know, lots to like in this strategy. I think Jason also makes a really good point, and I think it's a point that others in the room have made, which is just that recognition of where resources sit within the system. And if we want to take an approach that's more preventative, making sure we're able to shift resources into the community, and I would say, of course, working with people when they're younger, I think is important, but also looking at the distribution of resource across the footprint, particularly recognising the size of the Newham population and the youthfulness of the Newham population. The second thing I would say is just would like to see possibly developed a bit further the appetite across the partnership to innovate and test out different approaches across integrated delivery, and in particular how we respond to feedback from residents about how they would like to access support. And I'm particularly thinking about the need to change the way we respond to children and young people's mental health. And then the final comment, if I may, Chair, is just ensuring we've got the right prominence of social care, and in particular children's social care. I think the children's element is still very weighted to health, and I'd like to see a bit more focus on children's social care within that document.
Yeah. Excellent. It's as if I primed you on some of that about the references to social care within the document, but we have a long way to go. I think, Hilary, we heard some of that, but of course from other boroughs and not just Newham, but you'll have heard that across. It seems still quite a health orientated document, and we do need to make integration work. That's what's on the can. Simon, you may want to come in on workforce, as I flagged that one up.
Thank you, Chair. Thank you, Hilary. I agree. I think there's lots in the strategy to focus on, and lots of really good stuff in here that we can get behind, certainly as an acute provider to help deliver improvements in health in the borough. It's really great. My two questions relate to equity. It's really great to see that you've got equitable core service offer as one of the top points in there. I think we've really got to get on and make that equity assessment across North East London. I think the boroughs are at very, very different starting points. And I think unless we address that quickly, we'll continue to drive inequity in healthcare in North East London. So just starting to establish what services boroughs do and don't have, I think, is a really important thing we need to get on with urgently. I think secondly, I was fortunate enough to visit the Barking Riverside development this week. And we're essentially building a town on the Newham border without any health provision whatsoever. So there are schools that are going in there, but there's no GP, no dental practice. And essentially we're putting 45 to 50,000 people right on the doorstep of an acute general hospital, which is 10 minutes drive away. So I think we've got to really, really focus on population growth, particularly around Newham and Barking, which is where it's going to be at its greatest, I think. And we've got to combine planning in a little bit more of a sophisticated way, because we're probably going to meet our housing target in North East London, but we're not doing that in coordination with delivering the infrastructure that's going to be required, particularly in health. And if we don't deliver adequate access to health, we're going to drive further inequity and inequality. So we've got to join some of this stuff up in a planning phase really, really quickly, I think.
Thank you very much. Roxana, in terms of...
Yeah, I just wanted to pick up, Simon, on your comment about the growth potential of the south of the borough, the Beckton Riverside.
Barking, it was Barking.
Barking Riverside piece and the scale of development. Just to be reassured, the work that the local planning authority officers undertake, they assess the scale of any development in any part of Newham, and they will cross-reference that with regards to community infrastructure needs, including health facilities. So it's inaccurate to say or assert that there's no consideration of that, because there will be. And I think there's a more important strategic conversation that we need to be having as Newham Council with BARTS and the NHS relating to the capital money and resource required for our communities, for you to be building a state-of-the-art hospital to accommodate population growth.
Yeah.
And also what that translates to in terms of the pressures on existing primary level, and how you need to be resourcing our primary level sector, our GPs, our public health teams. So, you know, I just wanted to put that back to you, and I trust that you'll give that thought and discuss with your colleagues higher up. And I'm looking forward to that strategic conversation where money will be flowing through to Newham.
If I sort of just come in on this one, I've had a conversation with Simon and others, and Roxana, you'll know that I stressed at local plan discussions that there is something called NHS estates, that sort of the elephant in the room on some of this, you know, about the whole piece about where do we develop sites, how do we encourage. But I think the point is well made, Simon. It is in Newham and Barking and Dagenham that we look to local plans with NHS, which can be a little bit of a ivory tower in my experience in terms of central government departmental thinking. If we want localism to really mean localism, or integration to mean really integration, the strategy should reflect more prominence, as Tim says, on children's social care, but also adult social care, but the resources necessary for population growth, whether it's through the primary care hubs, the development of that, the growth in population of both. So Simon, do you want to come back? We could have an argument, not an argument, discussion, not an argument, discussion.
Is that Freudian slip?
Yeah. I could say in the intellect, in the intellectual use of the word argument. Does that get me out of it? Sorry, Simon.
I mean, I agree. I think for the hospital to be able to manage the predicted population growth, is going to need to be bigger. And we're going to have to look at how that is enabled, because I don't think we'll be able to manage all of the population growth through enhanced community services or hospital at home, which is what we're seeing a lot of in the media. I think securing capital to invest in infrastructure is going to have to come through the ICB, and that's certainly how the acute provider collaborative is linking with the ICB at the moment. I think what concerns me is that the planning around this hasn't really even started in terms of service provision and what's going to be required, but the building has started and people have moved into Barking Riverside, and there is no GP provision in Barking Riverside. So I think this is something that's this is a train that's already going quite fast, and to catch up will take some time.
I'll bring in Colin, who's and then back to you, Colin, because you're on what we call place now in this new sort of words. In other words, borough level.
What it means, Chair, is I'm wholly focused on the residents of the However, Hilary, I just wanted to make just a couple of observations, and I think it links to what I said right at the beginning, because I think what this plan doesn't do at the moment, it goes into what does it mean for someone in the I don't think it says, so what does that actually mean for our acute? What does that mean for primary? What does that? And I think that's part of the challenge of our partnership, is to be able to translate that and turn that into what does that look like. So I think in general terms, yes, I think, as Jason put it, there's nothing in here, and I think as you've heard from others that we wouldn't agree with. I think the challenge is the support that the ICB provides to place-based partnerships to make it happen. That's the real, and I think that goes to your point, Mike, it's about how we get people involved. I mean, as Julie and others would know, we have resident experience as part of every single agenda, on every single meeting we now have as part of that place-based partnership. So it's really crucial. And the other point just to pick out, which I think is really, really, really important for me, is that local employment of workforce.
Yes, yeah.
Because we go around now quite a lot in sort of health and social care, about how we can change, but I think there's a fundamental point in the capacity we have, and we need to address how that capacity over the longer term is going to be resolved. But whether that's in children's social care, adult social care, primary care, acute, nurses, community services, there is just a chronic shortage. The example I would always give is, every winter we've had money put into the system, and every year everybody says that's great, we'd love to do all these things, but we just haven't got staff to do it. So I think that's one of the challenges for us as a system that we need to overcome. But as a strategy, yeah, fully supportive.
Wax.
Yeah, I will just conclude and say that it's what I said at the start. How does Newham get involved? I know we've got our borough-based partnership where a lot of the stuff around the state, etc., and other challenges that we discussing today are picked up and then taken forward. But Barking Riverside side, we've got the biggest growth in that next door, the other side of the A13, around Abbey and Canning Town kind of way. And it'd be great to be sitting here in a year's time and say that we've broken that cycle of trying to catch our tails and be ahead of the game. That explosion that we had in that Canning Town area only just start to catch up in terms of health facilities, stock, etc., and stuff like that. But we need to be much more fleet of foot. That's where we need to make sure that Newham is involved in those big discussions. Yeah. And this is a big discussion.
Health facilities. Okay.
Quality.
Yeah.
That's quality.
Thanks very much. Now, I don't think that was an argument. I think that was a discussion. And Hilary, I'm giving you the last word. I think you'll have heard it from others when you've gone round with this strategy from the other boroughs, but we're a unique in Newham, because we're very challenging, as you know.
No, it's been, thank you all very much. I'm sort of conscious of time, but thank you for all of your very thoughtful comments. Just, I mean, in terms of the sort of population growth issue, I mean, certainly we can make sure you have a more detailed update on, particularly on Barking Riverside, if that would be helpful. But what we've tried to start to describe in the strategy is this context of absolutely huge population growth in North East London, and there's some associated work which is trying to model and forecast demand and how that is going to grow if, you know, unless we start to work very differently to address it. And that could, you know, that part of that is about more innovation, but some of it is also about just, you know, lobbying for resource and getting core services in place. I mean, I think the other bit to say is not just about sort of population growth and that demand. We have unmet need now. So, you know, that really does, I think that was really behind why we feel there needs to be quite a radical new approach to how we work together as a system. Just to reassure you, there is a group that is now meeting involving social care leads and public health input and colleagues from providers as well to coordinate the development of our joint forward plan, which is the delivery plan, which will say a bit more about all of this. And it will also, there's also a process to sort of link that with the developing plans within our place-based partnerships as well.
Now, I'm going to give the last word to Wax, because he's vindicating.
Hilary, just on that plan, and that's the important bit, that's the action bit, isn't it? How much of that is prescribed really from NHS England and the powers that be, and how much input will we have locally is quite concerned at the moment because it's not quite clear.
Yeah, so it's, I mean, we're in this unusual phase at the moment where the guidance coming out is relatively permissive. It was for the strategy, it has been for the joint forward plan. Across North East London, people are very clear that yes, of course, it's got to do the mandatory NHS bits that we're required to do, but what we want to do is make this meaningful and make it a delivery plan for our strategy.
It's interesting you said that, because as I say, some of us are involved in this strategy, and there's new guidance coming out in June 23. We don't want it tightening up if we're going to lose sight of that very important point. I think all partners will agree on that we should be innovative. We should be going around the same route all the time, notwithstanding all the other pressures in terms of equity and funding. Sorry, Roxanne. I was going to give Wax the last word, but I'll give you the last word.
I think this is going to be a conversation that carries on with scrutiny. I just wanted to ask, and talking to the point that was made earlier about there's a need now outside of population growth projections. So is I'm assuming the innovation is happening, or is the different iterations of strategies and the discussions sort of having to happen first? I just don't understand, given the pressures and demands of the now and the here, can we not just get on with it, please?
Yeah. So I mean, my view would, you know, there's two things we can do. We can try and make the best of the resources we have, which I think, you know, we have a whole range of work programs that are trying to do that. But going to Simon's point, you know, and the point that's been made in different ways by pretty much everyone, we need to grow that resource envelope to be able to do more. Because just through innovation, just through integration and developmental work, we're not going to meet the existing inequalities needs that we have and unmet health needs that we have in the borough. So it's both and, it can't be either or.
Yeah. I think that's a good point to pause, and obviously this is a standing item, colleague. Thanks for all the contributions and the hard work. Thanks, Hilary, for joining in, and you'll have to put up with me at the next meeting as well. Remember, I've written down some points from this meeting. Thanks very much on that. We've got to formally agree something, I'm sure. Yes. But
It's just for noting.
or was it just for noting? So we note that report. Sorry, I thought we had to agree something. And the next meeting, colleagues, is on the 6th of, no, what am I talking about? The 26th of April in this town hall at 6 p.m. if that's all right with everybody. Yes.
Lovely.
Thanks very much. Thanks for all everybody's contributions. Safe journey home. Thanks for everybody online for your contributions. And again, you're probably already home, but safe journey if you need to go home.
Safe.
Take care. Exactly.
Somewhere where I actually can read it.
Yes, indeed. We'll make certain. Sure.